Hello, this video lecture will cover Chapter 19, End of Life. This is a personally, I think, appropriate slide or quotation. The day of my birth, my death began its walk. It is walking toward me without hurrying. And that is Jean Cocteau, one of the French existential writers of the 20th century. It's basically, as soon as we're born, we start to die. That's a nice, cheerful thought to begin this lecture. What is end of life? End of life is defined as that time period when a healthcare provider would not be surprised if death occurred within about 6 months. There are very specific things that you have to keep in mind. Just because you're diagnosed as being terminal, it doesn't mean you're going to die immediately. That 6 months could turn into 9 months or could turn into 3 months. Dying is a process, and because it is a process, there is a lot that goes into it, and we're going to be discussing a lot of these elements in this video lecture. The other thing is that older Americans with chronic illness think about how they would prefer their lives to end, and most of us want a good death. We don't want burdensome pain, we don't want excessive symptoms, and we definitely don't want to be hooked up to all those machines. In previous centuries, when someone was injured or developed a serious illness, death followed shortly thereafter. And keep in mind that before the 20th century, we didn't have things like antibiotics, we didn't have heart surgery, lung surgery, transplants, we didn't have any of the major technologies that are used to keep people alive today. And because we have all of these advances in medical care, during the 20th century, the average lifespan increased by 30 years. That is a remarkable number. We have almost doubled our lifespan in 100 years. Of course, with extending our lifespan, we still have the inevitable of we're going to die. There's no way to get around that. The average age of death in 1900 was approximately 47 years old. With advances in medical science, that number jumped to 70 by 1970. And then since then, in the last 45 years or so, we've gone up to 77 years of age. So for men, you're looking at about 73 and a half years. For women, 79 years. And there are some issues about this difference between why women and men have a different life expectancy. The primary one is that biologically and evolutionarily, men are built for speed and strength, and women are built for endurance. So over the course of the last 2 million years of human history, women have developed the skill sets to stay alive longer in terms of our biology. There is a major issue in the African American community in the United States where we see the average life expectancy for men being around 67 years and for women about 74 and a half years. Some of the elements that go into that are some health issues with specifically heart disease and diabetes. And then there's the cultural issues of, up until a few years ago, you didn't see a lot of African American women promoting exercise or eating right, and smoking has become a very marketed tool for African Americans. So there's some issues that have gone on in the African American culture and community that has lowered their life expectancy. However, as people are recognizing these issues, the organizations that specifically look at healthcare for minorities have really been trying to get the message out. So where and why do people die? 70% of people who are 65 or older are the people who die. So if you look at everybody who dies, 70% of them will be at least 65. 63% of those people die in hospitals, and 17% die in institutional settings such as a long-term care facility or a nursing home. So despite most of us wanting to die at home surrounded by our loved ones, 80% of us are going to die in a hospital, inevitably hooked up to some sort of machine to keep an eye on us. That is changing to a certain extent for some communities, and we're going to talk about that in a later slide when we talk about hospice. The number one cause of death, heart disease. Number two, cancer. So it doesn't matter if you're white or black, the two biggies are heart disease and cancer. When we are looking at various other things, you do see different issues, especially in the black community with diabetes. So down here you'll see African Americans 4.2%, whereas Caucasians 2.6%. Of course, you also see a much higher rate of suicide for white people, but we won't go there. There are 4 types of death. Number 1 is clinical, which is when your heartbeat and breathing have stopped. It is possible to bring someone back from a clinical death using CPR. There are quite a few people wandering the earth who have been clinically dead and were brought back and go on to live very normal lives. Then we get into the death where you're not going to come back. Brain death, and this is when the cortex of the brain and the midbrain fail. People enter an irreversible coma, but their autonomic processes still work. So their heart still beats, they still breathe, their eyelids move, their fingers twitch, but their brain, that part of us that makes us who we are, is gone. Number 3 is biological or cellular, and this is when there's no electrical charges left in our tissue. This is when we're starting to decay. So our bodies start to change colors, the gases escape, the blood flow has stopped, and we are beginning to shift from a living, breathing entity to a decaying entity. The last type of death is called a social death, and this often occurs within a hospital setting when a patient is treated as a corpse even though the patient is essentially alive. There was a case a few years ago that caused a lot of attention. It was someone who was very old and they were dying. They were at the hospital. The orderly came in, figured that he would just save time down the road, and he put the person in a body bag and he just didn't zip it up. And the family came in and found Grandma put in a body bag, not zipped up, but just ready to go. And they threw a fit, and it became a big deal about not treating patients like that. But in a less hospital-related thing, just think about how often this happens. Grandma's dying, all of the family is together. Somebody says, well, you know, Grandma wanted Elvis played at the funeral. And somebody says, no, Grandma wanted the Beatles played at her funeral. And meanwhile, Grandma is laying there in a bed. Whether she's conscious or not is unknown, but you're having a fight about the funeral before Grandma's even gone. So what do people fear about death? They fear pain, they fear the symptoms, they fear the anxiety coming from what's going to happen. Are they going to go to heaven? Are they going to go to hell? What did they do wrong in their lives that are going to send them to hell? Which brings a lot of emotional suffering. It's also the realization that your family is going to be devastated by your death. And we also see advanced directives or living will instructions not respected. The concern there is if you do not want to be resuscitated or you do not want to be kept alive using extraordinary measures like a respirator, did you pick someone in your family who will respect your wishes? And a lot of times when you get right down to it, that person is unwilling to quote unquote pull the plug. So it becomes even more stress and anxiety for the person who is dying. There are other quality of life issues, things like, do you have a living will, which describes your care decisions if you are dying with little or no hope of recovery. There's also something called an advance directive. This is a document that expresses your healthcare wishes and preferences. It allows you to give specific information about your wishes. For example, whether you want to have a feeding tube, whether or not you want to be on a respirator, etc. And it also includes things like a do not resuscitate order, which is also known as a DNR. Older people have gone to the extent of having a DNR, the initials DNR, put on their chest, tattooed on their chest, so that if they are rushed to the hospital, the emergency room doctors, as soon as they would try and bring that person back using the electrical paddles to stimulate the heart, they'll see the DNR written on the chest, and they will stop trying to revive the person. Caucasians and Asians use advanced directives more than any other racial group. So if you're not white and if you're not Asian, I highly recommend you get information. You talk to your mom, you talk to your dad, you tell your grandparents. They should have these things in place because you never know. A 20-year-old could die in a car accident tomorrow. A 50-year-old could have a heart attack. This is the kind of thing that you cannot wait. It has to be done sooner rather than later. Other legal issues include a durable power of attorney for healthcare, which names the person you wish to make all the decisions for when you cannot. So, for example, if you have a durable power of attorney for healthcare for your mom, and your mom's only in her 40s, but she suffers a horrible car accident and she's in an irreversible coma, they're going to come to you, or you have the legal right to decide what care your mother will get. The other thing is the decision about organ donation. And again, a lot of times a young person in a car accident, brain dead, when they're unplugged, the organs can be harvested and put in people who can, survive through this gift. So a lot of these decisions need to be made before end of life. It just makes life so much easier for everybody, especially the family. Studies show that 67% of the elderly are in terrible pain 30 days prior to death. Studies also show that 33% of the elderly are in terrible pain 24 hours prior to death. So why are they in so much pain? They're dying. Why doesn't the doctor just give them morphine until they're numb and floating on a cloud of happiness? Well, doctors are often unwilling to stop treatment because they are reluctant to accept the loss of a patient. Remember, when a doctor takes his or her oath, it is to do no harm. And as a consequence, they always want to preserve hope. They want to keep you alive. That is their job. So they are reluctant oftentimes to give you excessive amounts of painkillers because that's not their job. Their job is to keep you alive as long as possible. Now, you may come from that perspective where you want to be kept alive to the very last second through whatever artificial means, and that's fine. But there are a lot of people out there who say, you know what, if I am not able to communicate, if I'm not able to have cognition, meaning think, I would like to be unplugged. And that's where you oftentimes have to look for alternative treatment options. Now, one of the major treatments that are used in the last 6 months of life is called palliative care. And it can be offered as an early intervention in the course of an illness, along with curative therapies. These are meant to prolong life for as long as possible. The alternative is hospice care, which focuses primarily on comfort and is intended to cease all curative treatments. So palliative care is a thought process where you're going to be receiving therapy that could potentially cure you and also keep you comfortable. And at some point, the curative therapy is probably going to be ending because if you are terminally ill, there's only so much cures a doctor can give you. Alternatively, in this palliative care scenario, if they can give you an extra month or 2 months or 6 months, that's really what people are hoping for. And you see this a lot when families are expecting something important in their lives. Someone's getting married, someone's having a baby, and they want grandma around to see the baby born. So they'll go through all of these curative and palliative care therapies to try and extend their life. Hospice care is completely different. This is end of life care provided by healthcare professionals. You have less than 6 months to live, and they're going to make you as comfortable as possible in the time you have left. They are not looking to extend your life. So they give medical, psychological, and spiritual support. The goal of the care is to help people who are dying have peace, comfort, and dignity. The caregivers try to control the pain and other symptoms so a person can remain alert and comfortable. They're not going to be in agony, they're not going to be in pain. Hospice programs also provide services to support a patient's family. And really, hospice is one of those very, very good products that you see a lot of middle class and upper middle class families using. But you don't see the low income people using it as much because they're afraid they're just being left to die without any support, when it's actually the opposite. Keep in mind that death is inevitable, and what they're really trying to do is make it as easy as possible for you and your family for the last few months that you have left. Now, health conditions for hospice patients, generally you see cancer being number one, end-stage heart disease, dementia, lung disease, kidney disease, liver disease, and then other is a variety of other kinds of diseases that a person can deal with at that age. The goals of hospice care are to manage the pain and any symptoms that cause discomfort or distress. They want to create a comfortable environment for the patient. They want to allow the patient to be close to his or her family and loved ones during the dying process. And they want to give relief to the patient's caregivers. When you are looking after an elderly relative or even a younger relative who is dying, the stress is extraordinary. And if you have somebody from hospice who can come in and help you out for a couple hours so you can just go out, go grocery shopping, take a walk, that is an enormous help. And it also offers counseling for the patient and those close to the patient. Death is a shocking experience for a family, and they oftentimes have to begin the grieving process before the person actually dies. So when is it time for hospice? Usually a hospice patient is expected to live 6 months or less. In 2012, approximately 44% of American deaths were under the supervision of hospice care. And hospice can take place at a variety of places: at home, at a hospice center, in a hospital, or in a skilled nursing facility, long-term care facility. My father-in-law had hospice at home for the last couple months of his life. He had a nurse coming to see him almost every day. We were given morphine in liquid form to put under his tongue the last few days of his life. Everyone was able to come visit him and say goodbye. And, really, it's a very civilized way of managing a very scary time period. Other end-of-life considerations. Some cultures, for example Korean, expect the oldest son to decide everything about the patient's or their parents' end-of-life care. So a lot of Asian families will defer to the eldest son in all decision making. And that becomes, a pressure on that particular person. And again, the legal documents that are required by a hospital don't always respect family culture. So those documents, those legal documents, are incredibly important. Minorities typically want aggressive treatment and are reluctant to enter hospice care because they have had prejudicial experiences in medical situations. The reality of the 20th century was that African Americans were not treated very well in a lot of hospitals. And as such, there are some very significant fears about going into hospice. To kind of put it in perspective, I have a little chart over here of hospice demographics. This is from 2011. Almost 83% of people who die in hospice care are white or Caucasian. You'll see down here, Asians, 2.5%. But remember, we don't have a huge Asian population in this country. We do have a large African American population, and yet only 8.5% will utilize this option. American Indians, who have also been treated shabbily by government and quasi-government agencies and hospitals, 0.2%. So really, it's an option that's not being addressed by a lot of the minority populations because of previous bad experiences. But it is a really good option for people. So let's talk about grief and mourning, because that becomes the dominant emotion even before the person dies. So grief is the combination of thoughts and feelings that one feels after sustaining a loss. Mourning is the process one takes towards the healing. Grief happens within the person, the internal, while mourning happens externally. And in some religions, they have external mourning traditions. For Christians, they have funerals. They may have an open casket. There is also, in Judaism, people sit Shiva, which is they sit as a group and are quiet together for the week after the person has died. Hindus will have a dinner 3 or 5 or 7 or 9 days after the person's death, where they will place a setting at the table with the person's picture, and the meal will be the favorite meal of the person who's died. So people have a lot of these external mourning. It's what happens with grief that is really hard to deal with, and we'll talk about that in more detail in a few slides. Anticipatory grief, which is what happens before the loved one dies, people experience depression. They have a heightened concern for the sick person. They anticipate the emotions that will occur after death. And there's an attempt to adjust to the consequences that are likely to occur after death. So if you know grandma or grandpa are dying, suddenly you're assailed with all these ideas and thoughts about what you're losing, all the conversations you never had, and it becomes almost overwhelming to think that you will never have the opportunity to speak to this person ever again. So the question is grief a bad thing? And oftentimes, especially in the United States, grief is viewed as something one needs to overcome or avoid and not experience. Someone who shows outward signs of grief can often be perceived as self-pitying or weak. But the truth is that grief needs to be experienced, not repressed, for healing to ever take place. In the world of psychology, we call this process. You need to process your emotions. You need to understand them. You need to experience them in order for you to gain control over them. And the truth is, we never get over our grief. We only become reconciled to it. It's like a wound. When it's raw, it really hurts. And then the scab, and it still hurts, and the scab comes off, it still hurts, but the pain lessens. And eventually you have a scar, and the scar will always be there, and it'll always remind you of the pain, but the pain will be lessened because of time. One of the most important research studies ever done on death and dying was by Elizabeth Kubler-Ross. And she wrote a book called On Death and Dying, which is one of the most important books to this day on our understanding of grief. She outlines the 5 emotional stages of grief and dying. Number 1, denial. Temporary response caused by the fear of death, losing a loved one, fear of losing control, and suffering. So you go to your doctor, the doctor says, "I'm sorry, you only have 5 months to live, you have inoperable brain tumors." No, I'm fine. I feel fine. You leave, you go have a beer, you go watch a movie, you're fine, no problem. But at some point, the reality is going to kick in. And then anger occurs. The injustice of why me? And this anger, you get annoyed at everything. When people are being nice to you, you want to tell them to, pound sand and leave you alone. And then the person goes through bargaining. They want more time. And it's not just the person who's dying, it's the family members. If you find out that your dad is dying at a very young age, you're saying to God, if you believe in God, why? Why him? You're angry. And then you're like, all right, listen, God, here's the deal. If you give my dad 6 more months so we can start the football season so we can go to a game together, I will give up smoking. So you start to bargain. After that, we go into depression, which is a severe despondency and dejection. And finally, we end with acceptance, where we face the inevitable. Now, here's the issue here. These are not linear. You can start with denial, go right to bargaining, go back to anger, go right to acceptance, and then go into depression. You can start with denial, go to anger, and then go back to denial. So these 5 stages are very um, amorphous in the sense that you can go straight through, you can go back and forth. There's no one way to grieve, and that's the important thing to take away from this slide, is that everybody grieves in their own way, but these are the categories of how we grieve emotionally. Here is generally what you see. It's a W. Time is our definer. We start in denial, we go to anger, we go to bargaining, we go to depression, and then we go to acceptance. And this is where our emotional state is. People, as they approach the end of their lives, want to resolve the following issues. They want to finish their life's work, meaning, if there's anything left undone, they want to make sure it gets done. They want to settle things with friends and family. They may want to see a friend that they haven't talked to in a few years, just so they have the opportunity to say goodbye. If they haven't talked to somebody in their family in a while, they want to say goodbye. And then they also want to reconcile their spiritual issues. And when we speak spiritual issues, it's not just a matter of believing or not believing in God. It's what impression you have left on people on earth, and you want them to think well of you. So the end of life is a very, very complicated time period. People go through a lot during this time period. Their friends, the family, the person who's dying. And the best thing anyone can do is to prepare when they're young. Because if you're 80 and you're dying, it's not easy to deal with. So that's going to finish the slide. Last lecture of the class. I hope you enjoyed it. If you have any questions, please text me or email me, and I will see you next week for the final.